morning to everybody. We are transmitting from San Donato Hospital in Milano, Italy, a procedure regarding the ablation of the substrate associated with long QT syndrome. This is the episode number 5, and we continue our efforts to demonstrate that the fifth chamber of the heart, so-called pericardial cavity, is extremely important because is the typical localization of the most important cardiogenetic disease, in particular Brugada, long QT syndrome, and early repolarization and right ventricular dysplasia. Why the fifth chamber of the heart, the pericardial cavity, is important? It's important because it's not just a small chamber, difficult to achieve, but is extremely important because the density of cells and immune mechanism may explain why this chamber is important and is the reason why most of the cardiovascular disease progress because the high activity in this chamber. So today we talk of long QT syndrome, but in the past we already demonstrated the presence of Brugada substrate in this chamber, and in the near future this chamber will be of more interest for the treatment of permanent atrial fibrillation, and why not most of the cardiovascular disease, in particular diastolic heart failure. And the reason of why the mechanism are here, because this chamber is very densely associated with the epicardial fact. So the pericardial chamber is this very teeny substrate. We have parietal pericardium and visceral pericardium. What is of interest for us is the visceral pericardium, very close to the epicardial fat. And for sure, behind its mechanical function, the epicardium is a dynamic layer that interacts with immune components, impacting with the arrhythmogenesis. So it's an essential compartment that houses the heart's immune cells and is important for both protecting the myocardium, but also to regulate the inflammatory response. And we are convinced after 10 years that this chamber play an important role in the heart rhythm and overall health of the patient through complex interaction with the epicardium and the myocardium. We can have a different situation in the real life. We can have healthy epicardium, inflamed epicardium, and fibrotic epicardium. The main reason of the disease associated with the substrate in this chamber is because we have an overactivation of immune cells, the infiltration of immune cells, the release of cytokines, the destruction of basal membrane, and in conclusion, the creation of inflammatory environment. And the consequence of this inflammatory environment is the creation of fibrosis, responsible for the mechanism and the substrate of most of the cardiogenetic disease. The most important cells in the pericardium is the mesothelial cells. And these cells have an important role as interface between the pericardium and the immune system. They are usually associated with other cells, in particular macrophages, fibroblasts, and lymphocytes. The molecules produced in this chamber are a lot. In particular, we have cytokines, chemokines, growth factor, and proteins responsible for coagulation and cell communication. So they produce a wide range of molecules, influencing obviously the inflammation, the tissue remodeling, and the fibrosis in the pericardium. Before to start the case, I would like to emphasize that in the pericardial cavity, we have this dense amount of fat. And usually the substrate of the cardiogenetic disease is localized in the middle of the fat. And this fat is extended not only in the right ventricle, but also in the left ventricle. In the right ventricle can be responsible of cardiogenetic disease. Its extension to the left atrium can be responsible for the progression of atrial fibrillation towards persistent and permanent atrial fibrillation. And the extension on the left ventricle can be the most important mechanism for the progression of diastolic heart failure. So the fat is not just a protecting structure of the heart, but is something more important, because inside the fat we have a dense activity of multiple cells responsible for the immune mechanism and the inflammation. At the end, responsible of the substrate. And also this fat can penetrate and invade the myocardium, creating the discontinuity of the impulse propagation and the condition for arrhythmogenic disease. Very recently, exploring this chamber in patients with Brugada syndrome, we found that one of the mechanisms responsible for the severe cases of Brugada syndrome is the production of autoantibodies against the sodium channel in patients already having impaired sodium channel function. But this is not just a mechanism associated with Brugada syndrome and cardiogenetic disease, but the immune mechanism and the induction of the disease due to the immune mechanism is responsible for the progression of valvular disease, conduction system dysfunction, coronary artery disease, and at the end, cardiogenetic disease. But coming back to the topic today, we deal today with the substrate of long QT. The typical substrate in a very advanced condition is associated with the reduction of the voltage of the visceral pericardium and epicardium, and the scatty distribution of this reduction in the voltage. And we will see that the substrate usually is composed by normal tissue, low voltage tissue, and fibrotic tissue. And this is an example. Typically, the electrogram is a double potential. This is a different condition compared with Brugada. In Brugada, we don't have any reduction in the voltage of the substrate, but we have a fragmentation and a prolongation of the abnormal electrical activity. Very similar indeed is to the long QT is the substrate of the early repolarization syndrome that we presented in the last case. Typically, during the natural history, the substrate in long QT progress year by year from double potential activity to the fragmented activity to the fibrosis. This is just an example I prepared for you to better understand the live case we are performing. This is the family history of a proband, the mother, resuscitated after cardiac arrest and discovered to be affected by long QT syndrome with this genetic abnormality in the potassium channel. The daughter and the son of this woman had the same EKG of long QT, the same genetic abnormalities, but typically the daughter was 20 years old, the son 30 years old. So looking at the importance of the progression, we had little different substrate, a little different EKG. This is the daughter EKG with a little prolongation in basal condition of the QTC, and during adrenaline test, we can prolong the QT until to 580 milliseconds. The son had a similar baseline EKG, but incredibly prolonged QT during adrenaline test. The case we are providing you today should be similar to this condition. This is the epicardial mapping of the right ventricle in the daughter, and you see the catheter is in the outflow tract, and we can detect this double potential. And these double potential are described with mixed colors and black dots. You see, in conjunction with double potential, we can have fibrosis on the anterior wall of the right ventricle. You can see the lack of double potential and the isoelectric line describing a fibrotic state. So in the same substrate, we have a double potential and no ventricular activity. Once again, we can define this region in two main regions, fibrotic area and double potential area. Most probably this area is just at the beginning of the natural history, and this area is in the late stage of the natural history. If we look at the substrate, the epicardial substrate of the sun, very clear we have again double potential in the outflow tract, but it could be elsewhere. But a lot of red region describing a huge fibrosis involving the region of tricuspid valve, anterior wall, and the inferior wall of the right ventricle. You see the fibrotic area correspond to the lack of ventricular potentials. And once again, these daughter and son have very similar geometrical configuration of the substrate, very similar morphology, and but they have a different type of progression. The son had much more progression. So daughter, more double potential, 20 years old. The son, 30 years old, has more amount of fibrosis. I think we are ready to start the case, but just to let you know, most of our patients had previous cardiac arrest, and our publication is based on patient with the previous cardiac arrest, prolonged QT, but not extensive prolongation. The prolongation does not correspond to the severity of the disease. And this is just an example of the different localization of voltage reduction and substrate modification in our case series. So before starting the case, I want to inform you that most probably the long QT is not a simple electrical disease, but could be an arrhythmogenic disease related to the substrate in the epicardial aspect of the right ventricle. Until today, everybody was convinced that long QT is a repolarization disease. Looking at this substrate, we should take in account, in particular, the depolarization disease, because we have the abnormal impulse propagation. So I'm ready to present the case, and then I go in the lab with my assistant, Professor Ciconte. This is a patient 54 years old with a family history of sudden death, with the previous syncope episodes, prolonged QT, and documented cardiac arrest in 2022. This is the photon counting cardiac CT showing that everything is normal. And this is the typical behavior of the cardiogenetic disease. Every imaging technologies doesn't show anything abnormal. Most probably because the thickness of the substrate is too teeny to be detectable with the available imaging technology, but we will see what we find. This is the EKG of the patient, typically a very prolonged QT at the admission. This is the documented episode of ventricular fibrillation at the ICD. The technology we are going to use is extremely important because it's determinant to detect the smallest possible potentials, avoiding as much as possible the interference with adjacent potentials. You see the mapping area of this catheter is 12 millimeter per 12 millimeter. We have 6 parallel splines. Each spline is 2 French. The catheter is 8 French. We have 36 electrodes. And this is the typical representation of the mapping catheter. And as ablation catheter, we will use the Q dot in combination with the visualization of the contact and the energy, the amount of energy we are administrating. So few minutes, I go in the lab to start the procedure. Thank you.
Thank you, Professor Forleo, for being our chair today. Giovanni, can you hear me?
Can you hear me too?
Thank you for joining us, and thank you for being with us.
Thank you, Giuseppe. It's again a great pleasure for me to stay here. It's the third time I'm assisting the World Life, and every time very nice cases. Now today is a very particular and tough case. It's long
Thank you.
population.
Thank you very much. So if you agree, we can send the transmission of the pericardial puncture in the meantime. So Alessandro, we have the patient already described by Professor Pappone. So we sent you just to review the pericardial puncture. Alessandro, please. So a pericardial access needle is introduced just below the xiphoid process, direct 30-45 angle towards the left shoulder, and upon injection of medium contrast, we secure the correct access into the pericardial space, and a soft tip guide wire is advanced through the needle into the pericardial space. This is extremely important to ensure the access. It was a nice anterior punch, and it could be appreciated by the fluoro projection. Afterwards, after having accessed the pericardium, we normally introduce soft introducer, an 8 French, and afterwards an 11 French, just to pre-dilate the access and confirm an appropriate space to introduce the deflectable sheath. After the introduction here, you see the 11 French introducer, just to pre-dilate the access and have enough space for the deflectable sheath. The deflectable sheath is an Agilis epi. Here is introduced over the guide wire inside the pericardial into the epicardial space, and after having nicely introduced this sheath, then everything is removed to allow the introduction of the multipolar catheter inside the epicardial space.
We have already the shell of the epicardial right ventricle. Professor Ciconte already did the mapping of the pericardial cavity. We did the integration of this map with the CT scan. And what is the QT prolongation, Giuseppe?
Now we measure that the baseline, the QTC interval. As you can see in the bottom of the left, we have 544 QTC millisecond duration. So it's quite a QT which is quite prolonged. According also to the patient characteristics that Professor Pappone has already shown. As he said, we had already also integration with the CT scan in order to visualize not only the morphology of the right ventricle, but also the coronary arteries, and we have the mapping here in the carto screen.
Integration?
Ben.
Giuseppe, you always perform CT integration in all cases?
We did intentionally for this live case, because in the clinical practice, as you know, it's not essential to have this integration, but in this case, it's extremely important to show and to educate the people how to navigate in the pericardial cavity. Important is the border between the right ventricle and the left ventricle. You see yellow is the right ventricle and green is the left ventricle, and between the two ventricular chambers we have the interventricular artery. So it's extremely important to avoid the ablation of the interventricular artery. But also important to know that on the outflow tract, the anterior wall of right ventricle, we don't have any circulation and any coronary artery. Also important is to know where is localized the left atrium, and the left atrium is near this region, you see. And this left atrium is of interest when the long QT is associated with atrial fibrillation, because in this case we address also the substrate of the epicardial left atrium. And also on the right of the map we have rotate a bit. We have the right atrium. You see this color. We have the right atrium, and it's important to avoid the wrong map of the right atrium. Also important to know where is the tricuspid valve. Usually the tricuspid valve is in the inferior region of the right ventricle, and we have the arrow indicating the substrate. That region is important because in the majority of long QT patients we have the most abnormal electrical activity and the reduction of the voltage. I think now we can start the mapping of the chamber. This map is the voltage map, because we know from the first index case that the main issue in this patient is the reduction of the voltage and the reduction of the electrical activity. So red means low voltage, and the other color normal voltage. Let's show a little bit the fluoroscopy to show where we are. Okay, this is the pulmonary artery, so it's not the ventricle. That's why it's red. Now we are on the ventricle and we start the mapping. Beniamino, can you tell what is the setting of the voltage map?
Yes, the voltage map.
We cannot hear you.
Can you hear me?
Yeah.
Yes.
Okay, the voltage map is now 0.2 as lower value and 1 millivolt as upper value, so that we can distinguish between healthy and fibrosis areas. Of course, when we map the pulmonary artery, we don't expect to have potential there, and this is why we get all this red up here. But as soon as we get the ventricular signal, we see that the map turns purple. Of course, we need to understand also the quality of the signal. As you can see, already in this area, we have some abnormalities. Yes.
Can I see the left ventricle?
Ventricle starts here.
So still right ventricle here. We have
Lasciala evidente, perché la togli?
nice signals here, which are indicating that this area is quite healthy in the right ventricle. And we are moving towards
We are at the
left.
border of
Yeah.
right and left.
So it is
I'm
important.
moving very
Yeah.
slowly.
Can you give us some insights on how to navigate in this area? Do you want to share something?
Yeah. Show me the potentials.
Ah, nice. Here we have something interesting. By moving the catheter in the anterior wall towards the tricuspid area, we have now interesting signals here, you see? What do you think?
Yeah, we have double potential here, see? Can you indicate with the arrow?
We have clear double potentials with isoelectric line in the middle, clearly indicating a depolarization, a late activity, very far away from the onset of the QRS, which is also interesting, but moving away from the left ventricle, right in this area, we have this very late activity, far away from the near field of the right ventricular electrogram, which is clearly indicating something abnormal, which is completely different as compared to what we have observed in the purple area. Here we have late activity as well. Yeah. Can you tag also this area,
Yes.
just to mark and highlight the region of interest?
Oh, we have fibrosis here.
Just a black tag will be fine.
Of course.
Or anyway, any kind of potential, also double potential. The light blue is okay. Light blue is fine. Okay. Also here,
Here we are very close to the tricuspid valve.
yeah, but still in the right ventricle. So this is important. I think that the first insight of using image integration is also helpful in the mapping, as you can clearly differentiate the location of the AV groove and the tricuspid area and the right atrium, right?
Yes.
But this is really interesting. These are really interesting signals with this late activity and delayed components, so clearly indicating an abnormal, area that, in our experience, is consistent with typical abnormalities that we observe.
Now
in
I
the
go
long
to the
QT.
left ventricle
Yeah.
to show that the signal should not be double potential.
And not so low voltage, because it's, and you see,
You see here, this is the normal potential.
this is still groove.
Groove.
Yeah.
That
Little
is the
bit
groove
down.
showed as red, but it's not.
Yeah, there you go. Here it's
This is a normal
nice,
electrical activity. See?
nice amplitude of the left
Yeah.
ventricle.
You see, it's very narrow activity,
Yeah,
not double potential.
and high amplitude also.
Delete the red zone because that is the coronary artery.
Yeah. Okay.
Just to show that these are normal potentials.
Okay.
You see, it's very normal potential, normal 8. And here we have transition between the right and left ventricle. And this is the typical abnormal activity due to the presence of the coronary artery. So let's go again on the right ventricle, just to emphasize that the right ventricle is clearly abnormal, a lot of double potentials, and now it's important to search fibrotic region that usually are responsible for the ventricular arrhythmias in this patient. And our target is also because we want to homogenize that region of interest. So
Here we have still a little bit
facci
of
vedere solo le
fragmentation.
mappe, così vediamo meglio i potenziali.
We have still a little
Professor.
bit of fragmentation.
What are the
Giovanni.
differences in mapping as compared to arrhythmogenic right ventricular cardiomyopathy?
Vai.
So
mapping.
the main difference that you may observe is the fact that the late activity you observe in arrhythmogenic cardiomyopathy is really delayed. Typically, the region might be similar, especially when you have a right dominant one. However, the late activity that you typically observe is mainly derived by channels and late activation with a very delayed activity. Here you have fibrotic areas with fractionation and late activity, which is not that delayed as compared to what we observe in right cardiomyopathies when we map due to VT. In fact, this could be the reason why typically we observe in these cases
very low
monomorphic
electrical
VT.
activity here. We see.
And in this case, we have VF. This could be the very well representation of the reason why in those cases we have polymorphic ventricular arrhythmias compared to a scar related that is a real scar within channels of late activation in right cardiomyopathies. Here it's a little bit still fragmented but less delayed, but still we have those fragmentations in the signal right in this area. We really need to define the borders in order to have a cluster definition of what could be the area of interest for targeting, to be targeted by ablation, and to define the LT tissue. And this is crucial in that procedure.
See here, we have little fibrosis, you see?
Yeah.
Can you indicate with the arrow the fibrosis? See? I need to be stable. I need to be stable. Now I am stable. See? Very low voltage activity here. I need to be stable and in contact with the tissue, avoiding the artifact. In this case, we can better detect the fibrotic region. Can you emphasize each signal associated with low voltage?
Although here we don't see huge fragmentation or double activity compared to the area that we tagged with the light blue dots. So this could be an area that should be spared by ablation, don't you think?
Yeah. But in any case, we
Here
have
is
a double
interesting.
potential
Look at
region.
this. Look here.
And
nice.
we have low voltage areas and fibrotic areas. So we have the progression of the substrate from the beginning to the end of the maturation of the substrate. And typically it's not a purple, unique purple color that we have in the left ventricle. So even we have tall activity here, all the activity is double potentials, completely different from the activity on the left ventricle. You see, on the left ventricle, you see very homogeneous and teeny electrical activity, and the color is homogeneously purple. You see, this is the ventricular activity, completely different from the right ventricular activity.
Right.
So the right ventricle seems to be very dishomogeneous, and when we look at this type of substrate, it's easy to predict that this is a depolarization disease, because the impulse propagation cannot be homogeneous and cannot be fast, because the presence of fibrosis can be of obstacle for the impulse propagation. And clearly you see here we have low voltage. See, very homogeneous region of low voltage, and the border is purple, showing normal tissue, but this region near the tricuspid valve is clearly or double potential or low voltage.
You want to see below on that area just to define, because I think that we have most identified most of the abnormalities. Here, although a little bit fragmented, but not as delayed as upwards.
Obviously, it's extremely important to do this type of mapping with high density cutter.
Yeah.
And with a 9 number of electrodes and with a very good contact.
I'm really
Typically
impressed. This is a really extensive area of abnormalities. Did you ever
I
try
think that
also mapping endocardially in this case?
the endocardial map, we typically at the beginning, we always start with the endocardial map, and the endocardial is normal in that region, the endocardium. So it seems that is really the superficial layer of the epicardium affected.
And
This
typically, the CT scan in this patient is completely normal. So it's not visible any fibrosis in the endocardium and in the epicardium. And the only technology capable to identify this low voltage region is the 3D mapping system, in particular the Carto system.
And also consider that I think that the most important area here is the one that we tagged with light blue and also
Here we have
black dots.
fibrosis, see?
Yeah, but in the area below, the one typically across the AV groove going down to the diaphragmatic area of the right ventricle, typically we have a lot of fat pads over there because you have the right coronary artery going down. And in fact, you lose this fractionation. So the most important feature that you need to address is the fragmented electrogram and the late and delayed activity, which is going, in this case, from the outflow tract close to the AV groove, going down anterior wall.
Let me see the integration with the CT scan.
And Giuseppe, is it possible to have dynamic changes in the mapping related, for example, to adrenergic tone or QT prolongation?
Well, typically at the beginning of our experience, we started to map in cases with not that huge prolongation of the QT under adrenaline test. And actually, we observed quite a little bit of widening of the substrate area characterized by the late activity. But the fibrotic area was pretty stable. In the end, when you have this huge prolongation of the QT, we don't advise to provide adrenaline tests. We have already over 500 millisecond QT duration, so in that case we tend to avoid. Instead, with 470, 480 milliseconds and clear demonstration, remember this patient was under nadolol as well, so she had on board beta blockers and which was poorly tolerated.
Here we have fibrosis, see?
Which was also
fibrotic area. This is not right atrium, this is fibrotic area.
No, this is right ventricle.
Very fibrotic area. Show again the right atrium, where is?
Yeah.
You see the right atrium is there, and this is a fibrotic area. It's far away from the right atrium.
And also here you have the
definition. A lot of fibrosis here, a lot of fibrosis.
Yeah.
And here we are very close to the tricuspid valve. And typically the fibrotic tissue is localized near the tricuspid valve. A lot of fibrosis here, see? We have the border with right atrium very fibrotic, see here? So we have the border between right atrium and right ventricle very fibrotic. In the middle, we have a double potential, so we have the transition between abnormal and very abnormal, and the purple indicates normal electrical activity. See here, it's very normal, very normal, no double potential. I move at the border looking at the double potential. You see, here we have double potential, and here we have the fibrotic area. So we have the transition from purple, very normal electrical activity. I am here now, very normal. Then we pass through the double potential region, and then we arrive to the fibrotic area. Beniamino, can you outline the pulmonary artery from the right ventricle? Just do not confuse the people. Okay. So this is the right ventricle is extended on the red, and the line should be moved on the right, because the white line corresponds to the endocardial mapping of the right ventricle, but the epicardial mapping obviously can have different border. Mi disegni il ventricolo destro epicardico comprendendo anche quest'area?
Show them the CT scan, it's much faster. Below. And then you move over there.
See, this is ventricle, Beniamino. So, okay.
So all this area below, we are mapping the right ventricle only. With some
And the
signals on the
fibrosis
left.
is just here at the
Those
border.
tricuspid valve.
Yeah.
I think that we have, we might have already.
Disegna il substrato da omogeneizzare. So the end point of this procedure is the homogenization of the double potential and the fibrotic area. Poteva coinvolgere l'area fibrotica, questo è efficiente. Vai tu. Beniamino, look my catheter, please. Okay.
We need to homogenize also the fibrotic area, so we are extending the substrate that will be a little bit also upwards. Ancora. Okay.
Qua.
Okay.
Qua means here. Mi date acqua per piacere?
And the QT shortening is not an endpoint of the procedure? Or?
Yes, we
eventually
expect that the QT will be shorter. We expect. And usually became shorter also the day after.
Also here, Ben, a little bit upwards, the part, the superior part, yeah, in the greenish area. Yeah, not purple, but in the greenish area, right. So from the pulmonary valve below. Okay, okay, it's fine.
It's fine. We exchange the catheter now. This is the Q-dot catheter, irrigated catheter. Can I know the setting of the power and temperature?
Yeah.
Alza la voce.
So we typically have a Q mode modality of ablation, so is a temperature control. We give 47 watts, and we are in the range
Dammi
of
la
the
mappa,
temperature
togli.
that will be within 39,
Vai.
43 degrees. So
Eroga.
typically our ablation strategy starts encompassing and covering the entire region of ablation, the entire region of the abnormal signals. It is our endpoint is to achieve a shallow lesion, so just to homogenize this epicardial substrate and not being transmural. To do so, we move the cath in few seconds, so the ablation time will be very fast, it is sufficient like that. We don't need to prolong our stay in each point to avoid the transmurality. During ablation, it's also important to have a retrieval of all the fluids that we provide during ablation, and this allows an adequate contact of the catheter with the epicardial surface. As you can see here, the bullseye is blinking in red, meaning that the temperature at the level of transition in the contact with the catheter and tissue is increasing the temperature, and this is important to achieve an adequate radiofrequency delivery in this region.
When we ablate in this region at the border between right and left ventricle, we must be careful avoiding the jump on the coronary artery. That's why the catheter must be moved very smoothly, avoiding immediate jumping. Can I have more water in the pericardial cavity? This is important because sometimes we remove too much water from the pericardium and it became dry, and this may impair the normal and smooth navigation.
It's also important, something that we didn't mention at the beginning, the sleeping of the catheter. The sleeping of the catheter, the multipolar catheter is important, so it's important to keep a saline infusion in the range of 2 to 5 milliliters, and also, just in case, inject a little bit of water inside the pericardium in order to get to have a space able to keep the movement of the catheter.
Just let you know, I am ablating the region of the most important interest, because usually the ventricular fibrillation occurs at the transition between double potential and fibrotic area, and in this particular region.
This is a region of a dishomogeneity. Actually, maybe this is the interesting part of why embryologically the outflow tract is hiding all these abnormalities in cardiogenetic disorders. What do you think?
Yeah, and also, Giuseppe, the presence of fat just around this substrate may explain, as I said in my presentation, why the substrate is localized here. So it's a regional substrate due to the systemic disease.
Yeah, right. And also, this might also explain why some patients may develop further in their life more events.
Yeah, we discover usually the long QT when the patient is 20.
Yeah.
But they start having ventricular arrhythmia also about later. 20 years later. And this is the case of this patient. He was diagnosed when he was younger, and he started to develop episode of syncopes and ventricular fibrillation at the age of 50.
And you check for possible right ventricular dysfunction after this so extensive ablation, or you think
no, because this is a very superficial ablation. We do not involve the entire thickness of the tissue, just fraction of a millimeter. And the same is for the ablation of Brugada syndromes. No, absolutely not. This is just the most superficial layer of the epicardial muscle.
We never observed any abnormalities, even in, as Professor Pappone said, in Brugada ablation, where we have extensive also, maybe ablation which is covering even larger areas, and we never observed abnormalities afterwards. So
the only consequence of this very wide ablation is the pericardial effusion, or the pericarditis pain. The pericardial effusion occurs in 5% of patients, but usually recover spontaneously without any necessity of pericardiocentesis. But as a standard therapy, we give colchicine and anti-inflammatory drugs for a period of 3 weeks. And we inject mepivacaina in the pericardial cavity, a little dose of prednisolone just after the procedure.
Yeah, at the very end of the procedure, we always advise to provide the injection inside the deflectable sheath, inside the pericardium, steroids and short-acting anesthetic drug, in order to have a dispersion of the drug in the pericardial cavity. And this allows, we have seen a huge improvement in the pericardial pain after the procedure, so the patients are recovering quite well without pain, or minimizing a lot this problem. So actually with this injection we are observing a very nice stay of those patients in the upstairs in the clinic.
And the sheet is removed just at the finish of the procedure?
Absolutely, yes. At the end of the procedure, we always check for any pericardial effusion, because obviously during ablation is an irrigated radiofrequency ablation. So of course, as you can see maybe with the camera, we are aspirating and removing all the liquids providing during ablation. At the end of the procedure, we ensure a dry pericardium with a transthoracic echo, and if this is the case, obviously you see that it's clean and we don't have blood inside, so everything is going well. And at the end of the procedure, we will remove the access right away, while the patient is still in general anesthesia.
And how much this procedure impacts?
The QT prolongation at the beginning.
At the beginning, we have 544 over there.
Yeah.
So we expect that this will, at the end of the procedure, will be shorter. Giovanni, please.
And how much this procedure impact on autonomic nervous system?
This is a very hard question. Apparently, the day after the patient is with little sinus bradycardia, but a few days later come back normal. Obviously, in the epicardial cavity, we have a dense sympathetic innervation. 99% of autonomic system, in particular of sympathetic system, are localized in the pericardial cavity. So for sure, with this type of ablation, we are dealing with the autonomic system. One of the concepts I developed is that the double potentials in the part where we have isoelectric activity is due to the insertion of sympathetic fibers into the tissue. And the sympathetic innervation can be responsible for the fibrosis in combination with the immunoactivity. Can we start the measurement of QT just to know the progression of shortening of QT?
Already we have to just to highlight that something in the repolarization phase of the ECG has changed in the precordial leads. You can see the T wave, which is more evident compared to the beginning of the ECG. Let's start measuring just to have an idea if something is changing. Apparently yes, but we need to measure just to be consistent and to compare our approach with the beginning.
I expect at the end of the ablation, but we see something also in this phase.
Something is, I think, is already there, but I want to see the numbers. So please measure it. Okay. Riduci la velocità. Reduce the speed of the paper just to help yourself in the measurement with the caliper. Go back. No, go back where you should measure. Right. Go to 50 millimeters second. Come on. Well, we have quite a reduction. We observed that it is 484. We had 50, 60 milliseconds reduction, which is quite impressive.
It's huge reduction.
Yeah, quite impressive.
From 545 to 484.
Yeah. It seems that we are doing something to this epicardium, right?
What is the reason of this reduction? Very simple idea. We reduce the amount of the epicardial tissue involved in the repolarization. This is a very simple answer.
Yeah. But in a way, it's something that is happening. It's something that we have also observed in Brugada ablation.
But it's huge reduction.
Yeah.
Before the end.
So it's a very nice endpoint,
and these results keep stable
over time.
Over time. This is interesting. So this means that it's not due to the sympathetic activation action, because we know the sympathetic system regenerate after the ablation, and independently of the regeneration of the sympathetic system, we still have shortening of QT.
Or by the way, it's not only the one involved, there could be multiple
My
effects.
idea is also that with this type of ablation we destroy the plasma cells embedded into the fat responsible of the production of chemokines and autoantibodies and molecules of inflammation responsible for the progression of the substrate. So clearly we modify the substrate forever because we eliminate the residence cells responsible of these substrate production. And this is the reason why we're thinking in the future to combine this type of electrical therapy with a pharmacological treatment targeting the immune system. I hope this will be possible very soon. And this could transform our work in the medical approach, not only electrical approach.
And you have already evidence of autoimmunity in these conditions?
Yes, we have data showing that before and after the ablation, the amount of plasma cells, lymphocytes, and macrophagy is dramatically reduced. But also we detect in the pericardial fluid after the ablation an enormous amount of triglycerides coming from the pericardial fact.
This is likely due to their involvement in the generation of the substrate and in the activation of the inflammation. Actually, inflammation is driven by the activation of the fat, and there is quite an evidence also in other conditions like arrhythmogenic cardiomyopathy as well, where the fat infiltration is providing a reason of the abnormal electrical tissue that we observed during mapping. So there are similarities in those conditions, and actually what we are trying to find is the common system and common thing that could get rid and explain why in those regions of the right ventricle we observe such abnormalities, and it is not only in one condition but in several.
You see, my navigation is very smooth, very slow. I do not stay on each point more than a few seconds. It's not necessary to stay. We don't have as end point to be transmural. We need to be very shallow, very superficial, because it's enough to eliminate this double potential. And for the homogenization, for definition, it's not necessary to stay too much on the fibrotic area, because we don't want to eliminate the fibrotic area, but we want to homogenize the border between fibrotic area and double potential area.
What we observed is interesting, as you see that in the middle, close to the fibrotic area of the tricuspid valve and the healthy tissue, we have a transition zone which is clear, and dishomogeneity or creating a dishomogeneous conduction of the impulse, and this may well represent
Giuseppe,
the milieu of why the patient has had VF.
It's the time to tell our colleague that after this type of ablation, we have been surprised that we did not observe any further episode of ventricular fibrillation on our first series of 50 patients. So clearly we are targeting the right substrate responsible for the cardiac arrest. And this is an unbelievable result. And also this should be taken in account. For definition, this ablation is not for all the patients with long QT, but it should be considered the first line therapy in patients with the previous cardiac arrest and frequent episode of syncope. I think this is the ideal approach to shorten the QT and to eliminate the substrate responsible for the ventricular arrhythmia. And we know the beta blocker doesn't work for a long time in preventing the cardiac arrest if the patient has the substrate for cardiac arrest, because it was understandable to use the beta blocker only when nobody was aware that the substrate is responsible of the clinical arrhythmias in long QT. Now we can affirm without any doubt that always in patients with the previous cardiac arrest we have a substrate detectable in the epicardial cavity of the right ventricle in all the patients.
And in your
On
opinion,
the other hand, in the patient, in the asymptomatic patient, we didn't see any particular substrate. Prego.
and in your opinion, is there still a space in some patients for left cardiac sympathetic denervation.
D2, D2.
Well, sure, this is the first representation of the presence of a substrate. So in our idea, of course, there is not always a black and white condition, but certainly epicardial ablation is providing a treatment which is directly involving the myocardial tissue. The sympathetic denervation is denervating something that is affecting something in the heart. They have two complete different approaches and concepts behind. For sure, there will be in the acute phase, for instance, in ICU or in the emergency room, just to mitigate a storm or something that is absolutely life-threatening. But I think that by modifying the substrate, and it avoids better the VF recurrences in these patients. So this is my concern, that the epicardial ablation might work much more in the long term, whereas
And we know
the
the
denervation might work in the acute phase.
And we know the success rate of stellar ablation is not 100%. Absolutely not.
Yep.
In this case, we didn't see any further episode of ventricular fibrillation.
Without complication, most
Without
importantly.
complication. Yeah.
And we never observed the complication with this approach.
And we did the procedure today within 1 hour, a few minutes. So nothing particular complicated.
So actually, once a physician is proficient and confident with the epicardial access or VT ablation physicians, they might as well replicate what we observe and well perform a procedure without particular efforts. So we believe that this is this is the first step. The first step was the definition of a substrate, an epicardial substrate in long QT patients in which we never considered or was never considered. So cardiogenetic disorders, they do have a substrate which is myocardial substrate, and we can treat it and can be homogenized by radiofrequency ablation. Then this is the first step. Then I'm pretty sure that guidelines will consider this strategy in the future as one of the first approaches, especially in the patient, as Professor Pappone said, the survivors to cardiac arrest with frequent VF and syncope. They may benefit of this procedure.
Can we measure again the QT prolongation?
And also you see that the substrate is going to be completely abolished. You see that the ablation is almost completed, and at the end of this we will again measure the QT interval. Can you measure the QT right now?
Cioè, come se tu non parlassi quando dici le cose.
Qualche volta. Ok. It's still 500, 510, so yeah. Anyway, it's shorter than the beginning, but of course we need to measure it back when the procedure is over. For sure, this is an adjunctive therapy. Wait a moment, go. Don't be in a hurry. Don't be in a hurry measuring. Let's finish the procedure and then we go for it.
And did you find any correlation between the extension of the abnormalities in the area and the genetic variants or QT prolongation or prognosis of patients?
No, unfortunately, another important aspect to emphasize, the long QT is not only associated with mutation in the potassium channel. The case I presented before the live case was due to the mutation in filamin, is a desmosomal gene. So because it is an arrhythmogenic substrate disease, we should expect the long QT not only in patients with mutation in potassium channel, but also in many other mutations involving desmosomal protein and not only channel protein. It's very similar to the right ventricular dysplasia. And I hope in the future it will be classified not as a channelopathy, but as a cardiomyopathy. This is clearly a cardiomyopathy. Not a repolarization disease, but a depolarization disease.
I think all these cardiogenetic disorders, especially in the most severe phenotype, they are sharing some features in the epicardium that might well be classified as epicardial cardiomyopathies. They do have some abnormalities over there, and of course the genetic environment is has an impact for sure in Brugada syndrome, for sure. In long QT, in these cases, we have too few cases to correlate, and I agree with Professor Pappone that we cannot state at that time to have a correlation between the genotype and the phenotype that we observe. Also because most of the patients they survive are cardiac arrest survivors, so they are the minority of long QT scenario. The long QT patients are not only the one having the cardiac arrest, but we have also the asymptomatic patients. So again, it's difficult to make a correlation like this.
We are very close
To complete
the procedure.
And you have experience also on short QT patients?
Well, short QT, they are very few. Not in mapping.
Most of them are Brugada syndrome.
Yeah, and most of them, perhaps they are even dying suddenly earlier in their life. So this is the reason why we might not observe so many short QT cases, but we didn't map.
But are very similar to Brugada syndrome substrate.
There might be. Try to measure now.
Should be much shorter now.
Seems to be, yeah. $500, yeah. In a way, we 44 milliseconds reduction, which is over 40, is absolutely a very relevant reduction. So we wait to complete the substrate abolition, and remapping will prove that we have removed the fractionation, and in that case we consider our target. Giovanni, our target is mostly oriented in the epicardial homogenization. And this was very clear for us from the beginning to homogenize the substrate and eliminate the fragmented components. And of course, in turn, this led to the QT reduction and shortening. But of course, remember, those patients this patient will continue as well nadolol. Unfortunately, not at the highest dose that we want, the dose that we wanted, because was poorly tolerated, and this is another problem with some beta blockers, right?
Yeah.
In some patients. But of course, we will keep pharmacological therapy. But the most important thing in this procedure is to homogenize the substrate first. And eliminating the abnormal electrograms is mandatory to achieve a good outcome and the absence of VF in the future.
And during follow-up, you observed a further reduction of QT interval?
The day after.
The day after, and they reach a reduction, and usually it stays unchanged over time at the moment, at the present. So, of course, it means that the modification of the substrate is persistent, and once you are satisfied in abolishing the abnormal activity here in the epicardium, once you get rid of them, then the QT interval follows.
Perché non metti i punti?
In my opinion, I see a less extent of ST elevation as compared to Brugada syndrome ablation.
Yeah.
Am I right?
Yeah.
Or-
No, you're right. You're right. Actually, the ST elevation in V1 and V2 that is typically observed in Brugada ablation is more pronounced. More pronounced. Here you see something. We truly believe that it is a matter of the reaction of the substrate to the heating. Brugada cells and Brugada mechanism in the cells of the outflow tract are way much more prone to react to the temperature. You know that we started at the beginning of injecting hot water or warm water to emphasize the substrate. In case of Professor Pappone at the beginning, he did like that. We have some bubble over there, and the warm water was able to provoke the pattern by injecting warm water into the pericardium.
Andiamo?
Should be fine.
Vai.
Okay, bye.
We had some bubble.
We had some bubbles in the line of the ablation catheter. Of course, we are in the pericardium, so obviously this is not something that we want during intracavitary procedure, of course. But we are aspirating everything, so everything is going smooth and fine. And we are going to complete the last line of ablation set in the lower part of the substrate. Next step will be to insert the multipolar catheter to see if in this area we have still something to ablate, and if this is not the case, we will consider the procedure completed. Inizia facendo lo scan, per favore. A due. Due.
Done.
Okay. So I think that the substrate is well completed. I think that we covered the entire area also by looking the signals behind, below the ablation catheter. We have much less fractionation.
Fagli misurare sulla B5. Discuti sulla B5. Okay, I think we can exchange the catheter.
Yeah.
I have to go here a little bit. Qua, vai. Vai. Eroga.
Erogo.
Ok. Top.
Rimisura. Ok.
Prendi.
Sì.
And you may pulse the atrium only in patient with atrial fibrillation?
Yes, exactly.
In all patients?
Vai.
No, just in patients with atrial fibrillation. We map the atrium. Otherwise,
Ok, lascia. Ok. Ok,
so
this is the remap.
is
You see, no double potentials.
we have nicely homogenized the substrate.
No double potentials. And the QTC is 483. You see?
But what is important here is the
And this is not a transmural lesion.
homogenization.
We still
here.
have electrical activity.
And most importantly here, we don't see anymore the fractionation as the beginning. Can you show comparison with the signals upwards, or you put another column?
It's very
down?
homogeneous, see? Very homogeneous. Very nice.
Can you show the signals before ablation?
Sleeping engineers, can you awake?
Okay, let's see here. Here you see the nice comparison
Before
and after.
and after.
You see after on the left. Alessandro, zoom on the Carto signals. Bottom panel right. In basso a destra. In basso. Okay. So here you are looking to the Carto screen with the
After,
signals.
you see very homogeneous.
On the-
Before, double potentials.
On the left panel, you see the live screen and the live signals, which are nicely on the left, indicate with the blinking arrow of the Carto here, good. Whereas on the right side, you have in the same area the double activity, which has been nicely homogenized.
So, very nice. No more double potentials, homogenized region, and the QT prolongation is now 483. I think the procedure can be considered very successful. Thank you very much for the next live case. Ciao.
Thank you.
Thank
Thank you, Giovanni.
Thank you.